Good morning, everyone. Welcome to the South West London CCG Governing Body meeting. Welcome particularly to committee members and to attendees of the Governing Body meeting, and to anyone who is watching this. This meeting is being broadcast live and it's also being recorded for uploading onto the CCG website. Members of the public will be able to ask questions live, and we'll do our best to answer them as part of the agenda item 11. Which is public questions. We've got declarations of interest for the register of members available in everyone's papers. There's also a glossary and acronym buster available on the CCG website for members of the public. And we're taking all papers and presentations as read, although I might ask people to flesh out just the bare bones of what's in the papers. We're assuming people have had time to thoroughly read and digest the papers. So we have apologies for this meeting from Jonathan Bates, from Dagmar Suna and Ian Dodds, and I confirm that we are quorate. So we shall proceed with the meeting. So first of all, let's just go to the declaration of interest. So just to check that the register of interest is up to date and everyone's interests are declared on that, and just to ask whether there are any particular interests we need to be aware of for the items in this meeting. No? Good, so I shall take that as accurate. So now we come to the minutes of the last meeting dated 2nd of February. So can we go through those for accuracy? What I will do, rather than getting up another screen and scrolling through, is just ask you if there are any issues of accuracy. Can you just put your hand up and flag them up? And if I don't see any hands, then what I will do is take those as an accurate record. I've just had a message to say that my camera might not be on. Now I can see myself, but can other people see me? You can, yeah, good.
See it.
So can I confirm with people that they're happy to approve those minutes as an accurate record of the meeting? Yes. Good. So those are approved. Then we just need to flag up some of the decisions that were made in part 2 of the governing body meeting before the last governing body meeting. So these are decisions that came from the 2nd of February part 2 meeting in private. So you have a paper on those, but I will just call out the different decisions that were made. So there was a decision made to enable a tender waiver to extend the current urgent care service model in Croydon. There was also a decision made to approve the procurement process to award the urgent and emergency care contract, the integrated urgent care contract, to PPG. And there was also agreement for the recommendation around the remuneration of the ICS CEO. That was reported in the verbal REMCOM report at the last part 1 meeting, but just to note that we had that discussion in part 2. So those are the notes from the part 2 meeting. I will pause there before we go on to the chair and accountable officers report and just ask if there are any questions about any of those items. No? Okay, so let's go straight on then to the chair and accountable officers report. It's brief, particularly my bit is brief, but the bit that I'm reporting is the really sad news that Naz Giovanni is stepping down as Kingston Borough Chair at the end of March, and so this will be his last governing body meeting. I just wanted to say, Naz, what an incredible privilege it's been and a joy to work with you over the last many years in South West London. I won't go over all the things that you've done in Kingston and prior to us merging and forming the South West London CCG, but certainly in the last 2 years, I don't think anyone would have dared to ask half as much from you as you've given. You know, just to list a few of the things that you've done for us, done for the system, done for the people of South West London in the last 2 years. You've led Kingston Borough incredibly through the most challenging of times. You've provided incredible support to Kingston Hospital. I know when they were struggling, you went into A&E and you saw patients yourselves, and you went on the wards to try and get people home when they were fit for discharge. So not only did you show great leadership, but you rolled your sleeves up and showed leadership in action, which I think was incredible. I've seen the work you've done with our acute hospitals. You've been a key link between the clinical leadership group in South West London and the acute provider collaborative and the hospitals. You've done a huge amount of work on the elective backlog and in trying to work through that and improve the care we're giving to patients. You've covered loads of London meetings. You've been leading on musculoskeletal and outpatients. And in many ways, I think you've been glue that has held things together. And I don't think everyone is cited on all that you've done and how important your contribution has been. But I am, and personally, I just wanted to thank you for your support to me, for the work you've done in the system, for the work you've done for the CCG, and the work that you've done for people in South West London. So that's all I've got in my report. But Naz, thank you so much on behalf of the board.
Sorry, Andrew, can I just come in?
Sure.
Sorry, I'm not used to this because I'm just going all a bit red, but you can't see that really. But I don't think without your support, Andrew, over the course of the last few years, that the South West London CCG would have been able to progress at the speed and the collaboration that is actually created, and the linking of your work across London down through South West London and actually holding the glue in the borough chairs as well has been really, really invaluable. And I don't want it to be a really nice love-in between Andrew and myself, but I think we do need to acknowledge that this is going to be Andrew's last Part 1 governing body meeting, and the immense contribution. It just cannot be written down in words or in or spoken about. There's just too many pieces that Andrew has actually led on, which have been really, really amazing. So thank you for your leadership, Andrew. Thank you.
Thanks, that's very kind. Vasa, I'll let you come in, but I know we Sarah's going to actually formally announce it in her section of her report, but Vasa, you come in.
Well, Naz has steered me in, so I will come in. Thank you. So Andrew, I speak as the man who never succeeded in succeeding you. So I think, first of all, Naz, thank you for all you've done. You have proved to us that we in clinical leadership can think not like GPs, but as system leaders. Because when you speak in London or when you speak at CLG or at the Senate, what came through to me was someone who knew what's going on the ground, but also someone who could connect up with a bigger, greater good people in London. And you never spoke like a GP. You spoke like someone who knew about patients, their sufferings, the system and its challenges. And to that, I thank you. Andrew, you know my feelings about you, so I don't think I need to publicly say too much. But if not for you, and if not for Nicola, and then for James Blythe, I won't be sitting here. So you're one of those 3 people who have looked after me in the last 2 years. And to that, I think to all 3 of you, I think today is the appropriate time for me to say thanks. And all what Naz said about you is true. You kept the confidence of the troops. The troops always knew that you would not sacrifice them in the process of your leadership and your professional advancement. You never did that. And you always you always felt the pulse, you heard the noise, you saw the tears, and you appeased the fears. Thank you, Andrew.
Thanks, Russ, very kind. Sarah, shall I come on to your Chief Officer section of the report?
Yeah, I do have a couple of sections before I come on to, and I know that the members of the governing body will want to join me around the discussion around Andrew, but first of all, can I just give you a little bit of an update on a couple of other things. So firstly, just on the terrible events in Ukraine, just so people are aware that we are actually supporting our staff who may be Ukrainian or may be affected by this because they have family in Ukraine, and offering them support through our health and wellbeing services. So just so everyone is aware of that we are actually supporting our teams and are making preparations should we need to for any impacts from that. Secondly, that the equality, diversity and inclusion work that we've been doing is ongoing. You'll see a brief report written in here, but we're going to do a lot more discussions with our staff over the next 3 months, and then we will be bringing back reports on how we're doing with that work and the plans that we're putting in place to help to tackle what's something that is actually a major issue for us, I think, in the NHS going forwards. So I just wanted to say that before, and I will welcome in other members of the governing body before I formally announce that Andrew, this is your last meeting as chair, and I just wanted to let everyone know that very kindly Dr. Nicola Jones has agreed to take on the chair role from the 1st of April until the end of the CCG, which will be the final meeting probably at the end of June, will be the last meeting of the CCG. And I'd like to thank Nicola. She is the vice chair and she's stepped up as chair from the 1st of April. So thank you very much to Nicola to start with. But also just my personal thanks to Andrew for all the work that you've done with me and with us across South West London. And I was going to talk about 3 areas. So 1, children, young people, mental health. We would not have been where we are in prioritising children, young people, mental health without your leadership, Andrew, and taking forward teams to actually focus on working very differently with schools and with local authorities in a way that we haven't done before, I think. And so, and we got a huge amount of money into South West London and much better outcomes for young people. More work to do, we know, but Andrew, without your leadership, that would not have happened at all. I can't let you go without talking about IHT and the work around Epsom St Helier and the many evenings that we spent in halls and other areas across South West London talking about the clinical benefits to the IHT work, and your leadership around that and your clinical leadership has been fantastic, and you know, at a very difficult time, I would say, and you know, we know that that was for the benefit of local people, and you stood up and was counted on that as a clinician leading that work. And then finally, the work around clinical leadership and the development of the clinical senate and that fantastic event that we had at the Oval that I remember so well, with all of those clinicians from across South West London. You know, it was something to behold, really, seeing all those clinicians come together and your leadership in bringing everyone together across the system to identify that kind of clinical role as forefront in South West London, I think needs to be talked about. So those were the 3 areas I was going to highlight. And Andrew, you know, we will miss you in your role, but you're not going too far away, because you're still going to help us on population health management for at least the next few months, and I'm sure you will be a part of South West London as we go forward as a local GP. So you may well not be the chair, but I'm sure you will be part of our system for the future. So I think that's really important as well. And I'm going to welcome any comments and from the rest of the governing body. Nicola.
Thank you, Sarah. So Andrew, you and I started to work together in Wandsworth and Merton. I think it was around 2014, but I might have lost track of time. And we were in these 2 CCG chairs roles, and we worked. The 2 CCGs worked really differently, really separately. And Andrew and I recognised that it was in our interests to sort of fast track our working relationship. So we invested some time in working on our problems before we had them, really. It was like a sort of accelerated marriage guidance, wasn't it? And that investment really paid off. And we went from really barely knowing each other into what I've always seen as a very constructive relationship built on mutual respect and trust. And I think we've had fun too, probably more fun than an obvious extrovert and an off the scale introvert have a right to, actually. So Andrew, thank you so much for everything you've done for Merton and for South West London, and for clinical leadership, and most importantly for patients and people in South West London, particularly for, as Sarah said, for young people's mental health, and finally for your support of me over the years, which I think you know, I've really truly valued. And I wish you all the best in the next steps, and I'm glad you're not really going too far. Thank you.
Susan.
I just want to pick up, obviously I've really only known you since you've been part of South West London, but as the lay member for public and patient engagement, I get invited to the clinical Senate meetings, and I'm just in awe really of the legacy that brings to the system, of the connectivity between primary and secondary care, the integration across the disciplines, and the fantastic work teams are doing really with patients to improve patient care. So if that's your legacy, Andrew, then I think you should be very proud. Thank you very much.
Thank you. Dino.
Yeah, thank you, Andrew. I wanted to thank you really for your outstanding leadership on behalf of the South West London system. All the comments that others have said, you should really register and take to heart. I mean, on behalf of South West London system and general practice, it's such a uniquely difficult time in our NHS history as well. Primary care and clinical leadership is certainly on a better footing as a result in South West London. That means that patients in South West London are ultimately benefiting. Your leadership in IHT will benefit many patients for years to come, and in Sutton we're particularly appreciative of that. I'm glad to hear you're continuing in a population health management role, and obviously we'll be working together on that. But always approachable, always thinking ahead, and a great leader. Thank you.
Thank you, Gloria.
Andrew, what can I say? It's very premature, really, to dump me in it. You know that, and we've had a lot of discussion around this. Andrew, really, I've learned so much from you. I came new into this to South West London, really not knowing anybody. I mean, you are one of the people that I've worked closely with. I've learned so much from you, more or less your patience, the way you work, how quick and the pace of work. And honestly, from clinical leadership point of view, and also to really have a clinician that will listen. And sometimes I've generally pushed our challenge out in terms of why is it always doctors alone? Why can't we have other professionals? And you've actually risen up to that. We've accommodated that, and I've actually made changes. For me, I was looking forward to working with you for a longer period, mainly learning from you. You know, we had a long chat around this, but you know what, it's sad to see you go, but I know you're around, and I'll keep in touch. I'll keep working with you, and we'll still continue to sort of move that drive from clinical leadership perspective. I personally just want to thank you for all your help and for all the things that you've done for people in South West London. And I know in terms of the population health management, your heart is in it, and I think we still have to carry on, and we'll carry on working in that good light. Thank you, Andrew, and best of luck in whatever you plan for in the future. Thank you.
Thank you, Gloria. Mark.
Andrew, be afraid I'll give you a non-clinical opinion. No, just to say that when I joined South West London and I was asked to be the SRO for the primary care cell, it was in the midst of COVID. And actually, just to say, with you and Nicola, there was a calm, there was a focused approach, there was leadership from really kind of incredible leadership, which was the response to our COVID in South West London. And just on a personal level, yeah, you're incredibly approachable, incredibly collaborative, and a great team player, and you really welcomed me in. So thank you very much for that.
Thank you, Mark. Millie.
Andrew, I'm sitting here listening to this as something of a beneficiary of your legacy, and I'm both very humbled and very nervous. What I just wanted to say, though, is you've been extraordinarily kind to me and very generous with passing on the information, and have treated me as a really raw newcomer, but who needed to learn, and I hope I have learned from you. And it's been a very, very positive relationship. So thank you very much for all your support of me as I've tried to make myself integrate into this great system. And I wish you all the best as a GP.
Thank you. And David, and then I think we'll hand back to Andrew.
Yeah, I'll say something about Andrew, but I'm not going to forget Naz as well. So hopefully he hasn't disappeared too far. Yeah, thanks, Andrew. I'll just echo what everyone else has said, because when I joined Merton, it was my first sort of non-exec lay member role since as I just retired from being a chief exec. So it was fantastic to have the opportunity, and thanks for your great leadership and guidance, really, both in Merton and also for South West London. So thank you. Everyone said it's a brilliant legacy that others can build on, and also to Naz, because I remember having a conversation many years ago with Naz when he was this young GP, and it was on the PEC, and at that time we were in Kingston PCT, and we needed what was a chair of the Professional Executive Committee, and me and my chair at the time, we twisted Naz's arm to take it on, and he's gone on to fantastic things. So really, on behalf of everyone in Kingston, great thank you to Naz as well. So and you've lasted a long time, Naz, so well done. Thank you.
Thanks, David. I was going to go back to Andrew, but we've got more hands up, so I'm going to go to Matthew, then back to Andrew.
Yeah, just briefly, I mean, I'd endorse the fantastic comments on both Naz and Andrew. I think, they are the encapsulation of genuine leaders, and I think South West London will be indebted to their contribution over many years, and we will feel your absence, although not completely away, I appreciate, but we'll feel your absence keenly, I know. But thank you for all that you've done. The only downside, of course, is that Andrew Murray is a fitter and better runner than I am, so I've still got work to do to improve, not just in the running but in lots of things, Andrew. So from me personally, thanks very much for all you've done, and I know you'll carry on making a big contribution going forward.
Thank you.
Thank you, Matthew. Right, Hugh, you're handing back to me. That was very nice, thank you. It's slightly embarrassing, but very nice. I mean, what I would say is I've learned a lot of things about leadership, but two key things. One is you're only as good as the team you've got around you, and I've just had a fabulous team to work with, both in Merton, in South West London, my fellow chairs, the executive team, the lay members, really fabulous people who complimented me and challenged me and supported me. So thank you for that. And the other thing I'd say about leadership is you're only as effective as your followers, because you can't really deliver anything as a leader without people who are willing to be led. And we've got fabulous people in South West London. So I just want to recognise that we've got great people in the CCG who who have delivered great things over the last couple of years. So thank you, everyone. OK, let's move on to item 5 on the agenda, which is the ICS transition update. Aaron.
I'm not quite sure how to follow that, but can I just also pass on my thanks to both of you for all the support and all the guidance that you've given to me over the years. OK, so we've got in the pack a number of things. There is the February headlines, which I'm just going to bring to life a few for those for you, but also just some thoughts and some work that we've been doing on the Constitution, and to ask the board to propose that. But I'm going to hand over to Ben to also do some thoughts on the Constitution, but also the due diligence that we've been working through the transition as well. But just to say, in terms of the February headlines, I think 4 things maybe to pull out of the report. I think the first thing is we summarised where we were with the proposals for governance at the end of December and sent them around to partners. Partners reflected on those and gave us their feedback throughout January, and we are just about to send out, after we present them to the Recovery and Transition Board next week, the summary and the changes that we'll make to the proposals based on the feedback of partners. And I should just say that everything that I talk about is based on the partnerships that we have in place across South West London and the combined work of all the teams to get us to this place. So the governance, I think, was a significant point in the transition, and we will make those final changes in March. In relation to place, each of the place teams are in the process of not only finalising their local governance and making appointments to some of the leadership roles, but also just finalising their health and care plans, so that actually there's a plan for the local boroughs to work together on over the next year. In relation to recruitment, recruitment to executive roles and non-executive roles are underway in the ICS, and we hope to conclude those by the end of March. And then just one final point, I think, to pull out in relation to financial delegation. Financial delegation and the way that we collectively manage funds going forward were agreed by the Recovery and Transition Board, and we are now working to begin to calculate and work through delegated budgets for the system as we move forward. So lots happening. I think we are doing incredibly well across a really complex piece of change, and all of the work streams are making significant progress. I would like to just thank everybody that's involved in that. We are, at the end of March, we will produce again a readiness to operate statement, which will show exactly where we are, but we're making huge progress, I think, and my thanks to all those teams that are doing that. So as part of that work, there is the Constitution. I'm just going to hand over to Ben to talk about the Constitution. When we sent out the proposals for governance, we also sent around the Constitution so that partners also were able to feedback on the governance of the ICB, the Constitution of the ICB. Ben, shall I just hand over to you?
Thanks, Karen. Hopefully the papers set out the background and the detail of the process that we've been through in drafting the Constitution. However, I was just going to pull out a couple of key points for the governing body. So the Constitution and the standing orders are based on the model Constitution and guidance that's been produced by NHS England. As opposed to previous exercises like this, a large amount of a Constitution this time has been prescribed by NHS England, with limited areas left for the ICS to draft themselves. Throughout the process, we've worked with and tested our drafting of the Constitution with our Governance Oversight Group. The Governance Oversight Group is an advisory body to provide expertise and input into these documents and our processes. It's made up of members of the CCG, the ICB, the wider system across South West London, key executive members from the CCG and our internal auditors. And throughout the process, we've also worked really closely with NHS England, again testing our drafting with them, incorporating their feedback as we go. And this version of the Constitution includes all of the recent feedback from NHS England. It also includes the latest updates to the model Constitution that NHS England released at the beginning of February. As Karen mentioned at the beginning of December, as part of our engagement exercise, we circulated the Constitution and standing orders to stakeholders across South West London, and where we can, this draft incorporates their comments as well. So I think it's probably just worth highlighting that it is possible there may still be some amendments to the Constitution. So the Health and Care Bill is still progressing through Parliament, and we haven't yet seen secondary legislation relating to that. So it may still be that there are some updates to the model Constitution. However, we don't expect these to be substantive. So as you'll have hopefully seen from the papers, both the legislation and the guidance asks for CCG governing bodies to propose the Constitution to NHS England. And just relating back to that last point I made, we're also asking that the governing body delegates the power to make any further amendments to the Constitution to the designate ICS CEO and Chair, so Sarah and Millie. Shall I stop there, Andrew, before going on to due diligence, and just ask if anybody has any comments or questions they'd like to raise?
Yeah, thank you, Ben. So I guess there were two parts to that. One was an update on the ICS Transition Program, and then secondly, an update on where we're at with the Constitution. So should I start with the ICS Transition Programme. Are there any questions on that? Yes, Susan.
I don't know whether this comes under the constitution or the transition, but obviously as lay members we lead on particular committees and things like that. So I can see where some map across to the new governance model, but I chair the Primary Care Commissioning Committee, and those functions won't necessarily be held in one place, they'll be distributed, but it would be useful to have a clear plan of action on how we need to manage that handover, as we have a couple of meetings before the end of the CCG, but it would be good to have some feedback maybe outside the meeting on how that works, unless you can feed that in now.
Shall I hold that one, Susan, and then I'll come to Pippa, and then we can get a response to the various issues that are raised. So Pippa, do you want to come in?
Yes, thank you, Chair, and thank you, Ben. So I'm very happy to support the recommendation in the paper. My question is, and it relates to the last item on this section around governing body meetings. So we've only got one more between now and June. However, the subcommittees are continuing. So really, Ben, it's a question for you. Based on that constitution, which we are proposing is taken forward, do you envisage any further work? Because the only statutory committees between now and the end of the June are the governing body and the committees that we've got in place in the CCG. Do you anticipate any further work for those committees in relation to this between now and the end of June?
Good question, Pippa. So that's more of a question for Ben, and then Bruno, do you want to come in?
Yeah, just very briefly. In relation to transition planning, Karen, there's been the new white paper in relation to health and care integration. Do you feel that that has implications for the transition process which are immediate, or do you feel that the kind of things which there are within that are things which the ICS will be able to deal with exclusively in due course? Do you think there's anything that needs doing between now and July?
Thanks, Bruno. Good question, but a broad question. So, Karen, shall I come to you first?
Yeah, sorry. So just in response to Bruno's question, the integration, I think, Bruno, actually, when we read the integration white paper, there's a lot of things that we are doing that are absolutely not affected by the white paper. So, you know, having a plan together so that you're clear, there will be, it feels, some national priorities that we'll have to take into account, but certainly in our reading of it, and it's still under discussion, isn't it, is that actually it doesn't affect hugely what we are doing. We're very mindful of it, but actually the way that we've been working actually is very similar to the white paper anyway. There will be things we'll have to take into account for, you know, national priorities, etc., that look like they're being set, and we'll have to think about if things like a single person have to be appointed, then how would we do that? But it's still in discussion at the moment. But it doesn't feel like it will completely take place. Of course, it's actually very supportive of what we've been doing. But there will be things that we'll have to be mindful of, I'm sure.
Thank you. And Ben, do you want to come back on the issue around the committees?
Yeah, so the constitution lists the two statutory committees that we have to have. We will obviously have other committees as well, and they'll be, the terms of reference, etc. Those will be included in the governance handbook. We've got a handover process in place for all of the committees to make sure that we hand over the work from the current committees into the new committees. So making sure that we don't lose that corporate committee memory, and that any outstanding actions continue, but we transfer the risks, etc. And I'll be talking to all of the chairs in due course about that. And one of the things we also have to do, Susan, which I think was part of your question. We have to create a governance and functions map so that we can clearly map where the decision making within the ICB flows. So whichever way up you want to look at it, from the board down or from the committees up, and that there's a clear sort of line of sight, if you like, from the board through the committees, and we're very clear where decisions need to be made. And I think, Pippa, that probably summarises your questions. I think the piece of work for the committees going forward over the next few months, as well as their BAU, is just to make sure that we've captured all of that work in the handover process, and that we're doing that handover from current committee chairs and members into the future organisation.
So Susan and Pippa, does that adequately answer your questions? Are you happy with that? Okay. Any other questions about the transition programme or the constitution? Are people happy then that we move to the actions that we need to take? So the first one is to note the updates to the Ics Transition Program. This is my last meeting, so I just got to say, I don't think we're doing justice to it just to note it. There's a huge amount of work going on to deliver this, and Karen, you're a bit of an unsung hero on some of this stuff, so I just wanted to call it out and say thank you for the work you're doing. I think it's fabulous. And I guess I'd also say, Sarah, you mentioned 3 things that I've managed to achieve in South West London, and 2 of them are the children and young people's mental health and the work with the clinical senate and the clinical conference. So I'd say on children and young people's mental health, both Karen and Charlotte provided a huge amount of support for that. So I just wanted to acknowledge your contribution to that. And on the clinical senate stuff, Karen, your support was amazing around that. So thank you again. So I just wanted to put that on record. But let's go on to note the Ics Transition Program. So are people happy to note that? Yep. And then in terms of proposing the draft constitution to NHS England, are we happy as a board to formally propose that? Yes. Good. OK. And then we need to agree to delegate the power to approve any further amendments to the draft constitution and standing orders to the designate ICS chair, which is Millie, and to the ICS chief exec, which is Sarah. Are we happy to do that? Yes. So that is approved. Good. OK, so should we go straight on then to due diligence, Ben, because you wanted to give us an update?
Yeah, thanks, Andrew. And as you say, this is just to give members an update on where we've got to. So I will take the paper as read again and just pull out some key highlights and background. So last year, NHS England again issued us some detailed guidance and a checklist around the due diligence that we needed to undertake to help us transition between the CCG and the ICS. The guidance sets out 3 levels of assurance in regard to the process. So the highest level of assurance is reserved for those CCGs who have not yet merged or don't have coterminous borders with their local authorities. The lowest level of assurance is for those CCGs who have already merged and have coterminous borders. And because of that, South West London falls into the lowest level of assurance around that, but because we believe it's a very helpful exercise and it's also best practice, we'll be following the checklist in its entirety. And just to give you an example of the things that list, that's making sure that obviously all of our accounts are transferred properly. That's making sure that we've got a full list of assets, so information assets, physical assets, people assets that we're transferring across to the new organisation. Work on the due diligence programme started in the autumn, and following the announcement of a delay between April to July, we spent January replanning that timetable and have again restarted the work to move towards July. So at this point, obviously, there's still quite a lot of work to do because the nature of due diligence you can't do. It's back-ended because of the sorts of things you're including, i.e., the number of FOIs we might have, or complaints, for example, can't be done right until the last of that. But at this stage, we don't envisage any risk to delivering the programme on time. I also just wanted to highlight that throughout the process, we're undertaking an internal audit for the due diligence at each stage of the programme. So this is going to look at our preparation for due diligence, our delivery of due diligence, and then the close down of the programme. And we had our first stage of that at the beginning of the year, and we received really good assurance around the work that we're doing. We won't get a final assurance rating until the end of the programme, because the audit is spanning the whole thing, but we didn't receive any management actions as a result of that first stage of the audit, and as I said, really good assurance around what we were doing, and I'm planning to take a further update, a more detailed update to the Audit Committee next week, to also keep them informed of what we're doing. I think, Andrew, that's all I wanted to say about due diligence. And then the last thing, just around the general update, was around the governing bodies and what's happening between now and July. And I think we've already covered that, so I won't say anything more.
Thank you, Ben. So any questions from the board on the due diligence update that Ben's given? People happy with that approach? Yes. Good. Okay, and that was for noting. So I think, Ben, we're probably ready to move properly on to the next item 6, which is the EPRR assurance outcome. Is that right?
Yes, that is. Thanks, Andrew. And again, this was just to give the governing body an update on where we are with our emergency preparedness, resilience and response planning. So you might remember we came to the governing body back in October to give you an update on this, and as you'll be aware, the CCG has to go through an annual EPRR cycle and self-assessment process. This process hasn't happened for the last year because of the pandemic, so this is the first time that we've had to do it for a while. So following the update we gave to the board in October, we submitted our self-assessment to NHS England in November, who assessed this in December. As you can see from the papers, the review found that NHSE gave a substantive assurance in 25 out of 29 areas that they reviewed, which is really positive, and I'm very pleased about. The 4 areas that we received recommendations on related to areas of our documentation that NHSE thought we could strengthen, but that's probably to note they thought we were coming from a very solid foundation in the first place. The NHSE review highlighted a couple of really key areas. So the strong relationship that we'd built between the CCG team and the regional team, the strong foundation that we'd started within our policy and planning processes, and also the strong foundation that we've got in building the new South West London Ops Room team, which take control of the EPRR process as well. So as you'll know, we got a small number, 4 actions out of that to strengthen some of our policies. We are well advanced with doing that, and I'm very confident that we'll meet the deadline that NHS England asked us to meet on that.
Thank you, Ben. Sarah, would you like to add to that?
Yes, just that this feels slightly surreal doing the EPRR just as we're coming out of a pandemic. Can I say that? Particularly as kind of we were a category 2 responder as a CCG, but I think we definitely acted more like a category 1 responder, if you know the difference, is actually taking action rather than just sort of being told. We were, you know, category 2, you're just advised what to do and support anybody that's doing anything. I think definitely with setting up our incident control and the way in which we worked across South West London, it felt much more like a category 1, and my understanding is that ICSs will be category 1 responders, so we'll have to do a lot more, but I think we've learned a lot during the pandemic, and it is slightly odd, but what I would say is the pandemic has shown us how important it is that we get this right, and actually probably the reality of what hit was not actually reflected maybe with the plans that we had, I'll be honest. So we had to do a lot more work, I think, at the beginning of the pandemic to get ourselves into the right place. So I think we don't want to lose that reality going forwards. So as we sort of look at EPRR planning, we need to make sure that there is a reality behind it, so that if we get another pandemic or some other incident that we have to deal with, that we are in a position to be able to stand that up immediately, which I think probably took a lot longer when we first started in the pandemic than we would have liked. I think, not that we didn't have a good response, but I would just say, you know, it's suddenly realization of the reality of actually going into pandemic, I think was quite surprising to a lot of people.
Yeah, thanks, Sarah. Pippa?
Thanks, thank you both. So absolutely recognise the significant work that's gone on here and the importance of it. So I absolutely agree with you on that, Sarah. So on that last point, I wonder, Ben, whether so, you know, we've got one more governing body meeting, but we've got couple of audit committee meetings, whether it's worth bringing an update on just those few actions that you've got to the last audit committee. I haven't had a chance to talk to Paul about this, so I don't know what his view is, just to confirm that we're handing over to the ICS in the best place possible.
Of course,
Paul,
Pippa,
would you
very
think that would be
happy.
sensible?
Yeah, sorry, just coming on screen. Yeah, I'm more than happy to do that, Pippa. As you say, I think we've got at least 3 meetings, including next Tuesday, between now and the end of June. So yeah, of course, we can take that on the agenda.
Thank you.
Thanks, Pippa. So are there any other questions about the report? No? So I'll take silence that people are quite happy with where we're at with that. So that was for noting, Ben. Thank you for that. We've noted it. And shall we then go on to item 7 on the agenda, which is the item of requesting approval for delegation of the annual report and accounts sign off to the audit committee. And James Murray, you're going to talk us through that.
Well, I think you've pretty much summarised it yourself there, Andrew, in your introduction. So I'm coming really just to ask, because the next governing body meeting is until the middle of June, for approval from the governing body to for the audit committee to sign off the accounts on the 7th of June on their meeting, which we do most years, I think, because of timetables. So it's a fairly standard process.
Was that it, James?
That is it, and as I said, you pretty well summarised it in your introduction.
So, any questions for James on that? Any concerns about that as a process? No. So, are we happy to approve that then? Formally approve that as a board? Is that yes?
Yes. Yes.
That is approved. Right, Tonya. On to something else that's been really quite significant over the last year or so, the vaccination programme.
Thank you, Andrew. And the paper you have in front of you provides an update on the COVID-19 vaccination programme, our progress to date, including the latest on VCOV vaccination as a condition of deployment, and our early thinking on how we move into the next phase of the programme. And the guidance for that was issued last week. So just to remind the governing body, since December 2020, we've delivered over 3 million vaccines in South West London, and the majority of them have been delivered by GPs and local community pharmacists. That's a fantastic achievement for South West London, but we didn't obviously do it alone. We did it, it was really a collective effort across the NHS, local authorities, police, army, the voluntary sector and community groups. And whilst we have some of the highest, we do have the highest uptake rates in London, in South West London, we continue to push our evergreen offer and continue to promote uptake, particularly in our areas of higher health inequalities and amongst people most at risk. And we get about 100 to 200 first doses every day, so it continues to be taken up. The paper lists a lot of our achievements, and I think they're really useful to see. And we are taking those forward, not just in our immunisation programme, but into the other services that we offer. The two areas that I'd highlight in those achievements is the recruitment of 1,500 bank staff, who many have now chosen the NHS as their preferred career route. So we've encouraged people to come and work into the NHS through the programme. And the hyper-local offer, working with communities, it's those pop-ups at a real local level that drives up the vaccination rates in our most needed communities. In terms of the vaccination as a condition of deployment, a consultation on that was closed on the 16th of February, and the outcomes were published by the government yesterday. And in light of this latest scientific evidence, views received as part of the consultation, as well as an analysis of the equalities impact, the government will bring forward regulations to revoke the vaccination as a condition of deployment. And you might have seen some of that in the news today. Just to say, just to assure the governing body that actually the uptake rates in our staff have been quite high. We have between around about 87 to 92% of our provider staff are vaccinated, and care home staff, it's 95%. So the current focus of our programme reflects the guidance that came out last week. So continue to provide access to the vaccine, both evergreen, but also 5 to 11-year-olds from early April. A focus on an increased uptake in all communities and addressing unwarranted variation. We need to build greater alignment with other vaccine programmes, and all vaccine sites are expected to improve population health. We'll be working with that with colleagues in local authorities as well in the NHS. And we need to plan for the autumn, but we know that the JCVI haven't yet issued the guidance on what the autumn programme will be. And we also need to develop contingency plans just in case there's another variant and we need to rapidly increase capacity. So that's my quick summary. The paper's there, and I'm happy to take any questions, Andrew.
Thank you, Tonya, really helpful. And before I open it up to questions, can I just say thank you to you and Matthew for your leadership of the vaccination programme. It was incredibly tough. It was a massive challenge, and I think we've responded remarkably well as a system. So thank you for your leadership of that. Thank you for everyone who has been involved, and I'd probably call out Charlotte's communication and engagement team as well, with the work they did in kind of raising awareness around vaccination and targeting some communities and groups who were initially not taking up the vaccine offer as much as some other groups. So well done on that. And I'd just say thank you to everyone who's been part of delivering the vaccination programme. And I mean that's all system partners, but as we're a CCG, I'll call out our GP members and the incredible way that PCNs and practices stepped up when it was needed as well. So thank you everyone for what you've done, an incredibly important piece of work. Any questions though for Tonya on the vaccination update? Susan.
Yeah, thank you. Can I just add my thanks for the incredible work everyone's done, and I've picked up quite a lot at the engagement steering group and feedback from Charlotte's team in terms of that. And I was interested to think that maybe this has had a sea change in people's minds about vaccinations in general, and not just particularly about COVID, where the people have been reticent in the past about any vaccinations. It'd be interesting to see whether that sustains really. And looking to the future, interested to understand that sort of wider immunisation programme. So when you talk about all immunisations, we're talking about childhood immunisations as well as, and that's presumably that's a responsibility for the ICS to have that duty of coordination, presumably with their partners around all of those, and working with primary care and PCNs really about how they're doing that. I think it's going to be an interesting time. Is that right? Am I understanding it right from the future? That's what's going to happen, is a bigger sort of model of working.
Yeah, absolutely, Susan. We have a South West London Immunisation Board, and we both in the ICS and regionally, we started to talk about the broader programme and taking the learning from the COVID vaccine programme into that. I think your point around we know much more now about the barriers to people accessing the vaccine or reasons why people don't want to have a vaccine, which we can also take into those programmes. So I would absolutely agree with you, Susan. I think there's lots of learning in both those areas. And we'll, as I say, we're starting to focus on things like childhood IMS as well now and other vaccine programmes.
Thank you. And Vasa, do you want to come in?
Thank you, Andrew. Just to follow on from Susan. Susan, the learning from this, the benefits of the communication engagement, the army of volunteers who didn't enlist but came up without much asking. Now, I think the communication learning and the army of volunteers are going to be the soldiers for Andrew in his population health management. And for the inequity agenda, we need this army because clinicians and managers alone cannot deliver equity and cannot deliver PHM. But these army of volunteers can and will. And I think we just have to keep the momentum going with those two agendas and realize there's untapped potential which we utilize for the vaccine program. Now let's use it for equity.
Thank you, Vasa. Any other questions or comments for Tonya? No? Okay, so we will note that, Tonya, and thank you again. Let's go straight on to item 9, which is the board assurance framework. Ben.
Thank you, Andrew. I think this is my last agenda item, you'll be pleased to hear. As members will be aware, twice a year we bring the board assurance framework to the governing body to update you on the current risks facing the CCG in our delivery of our objectives. The BAF risks are made up of two sets of risks, so those scoring 16 and above, and also those that are of a sufficient significance, but we want to bring them to the governing body's attention, but are not currently scoring 16 or above. Just to note, we're in a really good cycle with the risk register and the BAF at the moment. So both the BAF and our corporate risk register are regularly reviewed and discussed at all of the governing body committees and also regularly reviewed by the CCG's SMT. So I won't go into the detail of all of the individual risks, but obviously I'm very happy to take any questions around them. But just to summarise, we currently have 4 risks that are scoring over 16. We have a further 4 risks that are scoring under 16, but we wish to bring to your attention. We've added 2 new risks to this BAF, so one regarding workforce capacity and well-being, which is something we've discussed in various committee meetings and possibly here before, and also one regarding the delivery of the Ics Transition Program and our objectives around that. We've closed 2 risks because they are no longer live, so namely the risk around CMC procurement and the risk around the availability of blood vials. And then finally, we've removed a further 2 risks from a BAF, but they remain live on our corporate risk register, and that's around the increased demand for mental health services and also the rollout of the COVID vaccination programme. So that's probably all I wanted to say in summary, Andrew, but obviously I'm really happy to take any questions about the detailed risks themselves.
Thanks, Ben. Nicola.
Thank you, Ben. All makes perfect sense. Just to flag, though, I think the blood sample bottle, it just flags when, you know, when we take a risk off the register at the level of the board, it sinks down to the level at the front line, actually, and so it's not no risk. So we've got blood sample bottles now. I think it's safe to say that supply is vastly improved, but not quite back to normal. But the backlog of patients who didn't have their blood tests, you know, the NHS health checks and the routine monitoring, is still there, lying in general practice. So it's taken a different form and a different level of kind of, you know, severity, but it still lies in our system.
Thanks, Nicola. Why don't I take all the questions, Ben, and then you can respond to them in the round. So Susan, shall I come to you?
Thanks. Yes. I was looking at the IUC risk and lots of mitigations around managing the contract we've got with the current provider, but just wondered whether we should reflect on the fact that we've got a new procurement process that's now completed and that service will move to a new provider. So that's in terms of what we're currently receiving, and that's a mitigation, an action that's taken place. But also perhaps there's a new risk around securing the integration of the new provider into the system that needs to be flagged up. I think it was highlighted earlier in the meeting, but perhaps we should be looking to add that to the risk register as we move forward. I don't know whether the timing of the implementation, but I'm sure that even though the contract might have started, the implementation will still be a risk that continues as it gets embedded. But
yeah, thanks, Susan. Good point. Pippa?
Thank you. Thank you, Ben. So yes, I'd agree with Susan's comment. And the fact that we've got governing body members on the oversight committee indicates that I think there's still an ongoing risk around that on the implementation of the IUC contract. And I also agree with Nicola's point. I think it's a really important point. It'd be helpful to know where that risk, so it may not be on the BAF, but where is it going to sit? Because the backlog in primary care as a result of the impact of the blood vials is really important, and it does need to have some oversight. So it'd be good to know where that's going to be overseen. And then my two questions. So I'll just pick up on ones that you closed. So you closed the coordinate my care risk. So absolutely, I agree with you. The implementation again has completed. However, the procurement has completed. At the Finance Committee this month, we've agreed a single tender waiver because there is a gap between the Royal Marsden service finishing and the new provider coming on. There's a mitigation in place, but Tonya's agreed to bring a paper to QPOC next month to give us some oversight of the risks and mitigation about just how we're managing that integration between the existing system and the new system. So I think that remains. I know that you put it on the corporate risk register. And then my final question, which is on risk 112, might be one for Karen. Really helpful to see the workforce in here, and I agree it needs to be on the BAF, so good to see it. One of the actions required states that a mitigation for this is the South West London People Board. So a couple of questions on that. Is it in place? And are they reporting to the recovery board over the next few months? Because I think it's important that we state here there is no formal way that is reporting into anything to do with CCG. So it doesn't come into QPOC, doesn't come into governing board. So it's really important someone is providing some oversight to that. Thank you.
Thanks, Pippa. And let's hear from Patrick, and then Ben, maybe you can coordinate the responses to this, because not all of them are risks that you yourself own, even if you're responsible for the framework. Patrick.
Thanks, Andrew. Thanks, Ben. So just in the context of the blood bottles, are we confident really there's a national action to address the dependency on single providers and where there isn't enough resilience in the system, and by extrapolation, are they nationally considering other areas where there is absolutely key equipment that we might run into? So is there a process to address that outside of blood bottles as well?
Okay, so Ben, if I might summarise, there's some concern around the blood vials that although we've taken it off the risk register, there is still an issue, partly related to the backlog. So I think we just need to be confident that if it's not on the risk register, it's still being, we're still mindful of that, and there's still some action in place to just keep track of the impact of that. Patrick's question about what's the national team doing around issues of supply, I don't think we'll be able to answer in this meeting, but I think it's a point well made. And then there's specific question around the integrated urgent care procurement, the fact that we've got a new provider and the risk around mobilisation and implementation, and the risk that always happens when you bring a new provider in. And I know one of the things that we have discussed before all the way through this process is the risk around integration with primary care, particularly with extended hours provision from primary care, and that's something we have asked specifically to be addressed as part of the mobilisation, that those links and connections and that integration is sought. So I guess that's something we'd want to be making sure we're keeping an eye on, and specifically Pippa's point about CMC, which is okay, so there sounds like there's a gap and there's a mitigation in place, and how much of a risk is there around that mitigation, or are we really confident that that is sorted. And obviously, Pippa, you've also just flagged the workforce issue, which might require a response from Karen. So a number of things there. Ben, do you want to go first?
Shall I try and work through those? So yeah, on the blood vial stuff. So thank you, Nicola. I think you make a really good point. Let me work with Mark to see whether there might not be that there's a specific risk that we need to create around that. It might be that we have something that we can already add that to. But let me have, because we have a primary care risk register, obviously. So let me have a chat with Mark, and we'll work out something around that. Just to address Patrick's one. So. With regard to our one, my understanding is that you know, sort of the risk's been decreased because we've got a good stockpile, and we know that there's a good supply chain behind that. I think your point about whether there are other areas is well made. As Andrew said, I can't answer that here, but we can certainly go away and answer the questions. Ask the question, sorry. Susan, on your IUC, yes, Jonathan was cognizant of that. This was sort of fell into the reporting cycle that we had in the time, and obviously getting to that. So we've asked Jonathan to make sure that he reviews that risk, both as it stands on the corporate risk register and to make sure that then that obviously feeds into the BAF, and I'll make sure that your comments are fed into that review as well. On Pippa's points, then I'm going to ask Tonya to probably come in on the CMC point, and Karen on the workforce issues. Tonya, do you want to go first?
So yeah, sorry, yeah. So you're absolutely right, Pippa, that we've extended the inter-systems to support for 3 months. Though what I would assure the governing body that the oversight of this is, whilst it's a delay in mobilisation, there isn't a significant risk in that. And I know that's hard to understand when you think you've delayed the mobilisation, but the clinical oversight and the migration is going well. I checked, so we have an oversight group that meets regularly, and we check that process. So whilst it's a delay, and actually for the front end user you won't see that delay, it will look the same on the system. And then we've actually continued to encourage people to use the shared care plan record, and people are, you can see by the uptake rates, they're similar month on month. So whilst there has been that delay, actually I think the risk to delivery is low, but as I say, we'll come to QPOC and talk that through to you in more detail.
And then workforce, Karen.
So yes, so there is a people board in place, Pippa. It's chaired by Joe Farrer at Kingston. It reports into the Health and Care Programme Board, so it's a South West London ICS committee rather than a CCG committee. We are actually reviewing it as part of the transition to the new ICS, and one of the things that we saw for the first time at the last meeting was a system workforce report, which helps us then obviously track the impact on people, and we'll continue to develop that. So yes, it's not a CCG responsibility. It doesn't dock into our governance. It docks into the ICS governance.
Thank you. So are we happy now with the board assurance framework, and people are happy for us to note that then and move on? Yeah. Okay. Good. Helpful discussion. Shall we go into the committee updates now? So we've got a report from the Finance Committee. That's the first one, James. So over to you.
Okay, I'll try and keep this brief. So you've got the month 10 position there in terms of where we're at as a CCG. Just a couple of points to note, really. So as people are aware, we've seen rising costs in CHC, which had plateaued and gone down a bit. They've bumped up again a bit in the last month. So we'll work with CHC colleagues to understand what that is and how that manages, particularly as we move into the new world and we start delegating budgets to place. So, but we do have a recovery plan on that, so we'll work through with that. The other one, just to note, and I think it was flagged by Susan at the last meeting around primary care budgets and the way we manage those. So I've met with the primary care team since there, and we're coming up with a plan on how we manage that as we go forward. And I think Susan's point there was how we manage some of the shifts in cost and the delegation position. So we've started that work, and we'll continue with that. So so that's where we're up to on month 10. Confident we'll report on plan for the rest of the year, and we'll bring that back to the June meeting once it's been signed off by Audit Committee. In terms of next year, we've now commenced the planning process for next year. Next year is going to be a whole different kettle of fish, as people are aware. It's going to be a big challenge for the system, given the change in the way the funding works. So that work is underway. Just in terms of how we manage that going forward, because clearly we've got 3 months of a CCG and 9 months of an ICS, and we haven't got another governing body meeting till June. We'll be working with the Finance Committee in March and April to make sure that the CCG understands what its obligations are for the first 3 months of the year, and then obviously how we transition that into the new ICS from July the 1st. So we'll be working with the Recovery Board and Finance Committee to pull that together, just to give people assurance that there is a process on how we're managing next year's plan, and we'll be taking an update to the next Finance Committee. And that was happy to take any questions, Andrew, but that was basically the update on finance, unless David's got stuff that he wants to add.
Thanks, James, really helpful. Are there any questions for James? What I can do is go straight to David, and David, you could give us your perspective and perhaps just talk us through the Finance Committee report as well, and then if there's any questions following that, we can take it in the round.
Yeah, thanks, Andrew. No, I guess the main issue is this one around continuing care. So we did have a couple of months ago, Gloria and other colleagues came to the Finance Committee to run through the plan. So and that was a really good discussion. And then we did another review in terms of where were we at on continuing care at our meeting a couple of weeks ago. So that's clearly, as far as the CCG part of the business is concerned, that's where the big financial risk is. So we'll continue to look at that. Just from the Finance Committee, there are still a lot of single tender waivers that we're having to approve. We've done a lot of them, and we're taking a lot of these out as separate meetings for the Finance Committee just to get through them. So we're all aware of some of the issues around this, so we're continuing to do that. And then I think the main issue, it's managing, as I think others have referred to, it's this transition and handover now from what the CCG has been doing into the new ICS. So what the other group that we still have, and just to mention, is the group that I chair with the finance leads and finance non-execs from each of the trusts. So that gives us another opportunity to at least ensure that there is some sight on what we're doing through that group as well. And we will continue to do that. We've got a meeting with the non-execs of the trusts Friday of this week. And again, we are running through particularly the handover, and also how does then we deal with the planning and budget setting for next year, because that then becomes the next critical piece to do. So thank you, Fernando. Happy to take any question.
Thanks, David. So are there any questions on finance, on the finance report or the report from the Finance Committee? You both set it out very clearly, and David, confident that in the Finance Committee you're going through all this in a fair bit of detail. Good. Okay, thank you. I'll take those as noted. Should we go straight on to the performance report? And it is, we have the privilege of Sarah Blow giving the performance report.
Thank you. Yeah, don't ask me too many detailed questions, please. I think it's the opening part of that. No, so you've got the full performance report in front of you. What I would say is, as always, this is a couple of months out of date. So I was just going to put your attention to a couple of areas, but also say what's happened, I think, since. So first of all, on A&E and 111, obviously we've seen quite a decrease in delivery on the 111 contract through Vocare, but we're hoping now that we have we are implementing a new contract coming through into June that we are going to see a significant improvement in that going forwards. But I think it's worth highlighting that because that has been a problem over the winter. A&E performance, again, we are struggling with A&E performance. This is a few months ago, and it was the impact at that point of the Omicron virus that we're reporting on in this report. But what I would say, and I'm sure that Matthew would support me in this, and it's mentioned later on, is that our biggest problem at the moment, and particularly in Croydon, appears to be mental health patients in A&E is causing us some significant delays in A&E in South West London, but particularly in Croydon. So we are doing some work on that to try and understand what the issues are. A&E in Croydon, I think, have consistently got a number of people in crisis within their A&E department, which we need to work with SLAM and South West London St George's to see what we can do about that. So I thought those were worth highlighting. You will see the recognition of the work that we're doing on planned care. Can I say that planned care performance has increased significantly since this report? So on this report we are saying around 70%. The last report I saw, we were at 104% of our planned care delivery, which is very close to what we're required to do nationally. So that was a very positive piece of news that I saw the other day. And cancer has improved slightly, but we are still looking particularly at breast cancer, where that is a London-wide problem around the breast pathway, which we need to deal with jointly across London. So I would draw your attention to those areas. I would say in mental health we're actually doing quite well in some of the areas that we are measuring around IAPT and around dementia diagnosis, even though we've had the impact of the COVID. But what I would say is this big issue around mental health is particularly around A&E and particularly in Croydon. Shall I pause there? I mean, I'm happy, and I'm sure my colleagues would be happy to answer any detailed questions, but that gives you the kind of highlights of some of the areas we're looking at.
Thank you, Sarah. So, Susan, can I bring you in?
Yes, I mean, a lot of the areas that we're trying to tackle require the development of recovery plans. We've heard about those in place, and though that primarily is about reducing backlogs, securing capacity, improving productivity, I just wondered how much connection there was between those recovery plans and the bigger picture about any inequalities that might be in place around people even coming forward for some of those services. Is there a connection being made? I presume at the moment it feels like there's a sort of an urgency to deal with the demands that are sitting there, but we obviously do quality impact assessments when we put plans together, but it was also, I was just reflecting back on our previous discussions on population health and the issue of inequalities, whether we're starting to do inequality assessments really on how we're delivering some of those services. Because if you're putting in a recovery plan, my assumption is that there's an opportunity perhaps to look at a different way of delivering, as well as just adding capacity to do things in the same way, and therefore linking it with other strategies that are going on around prevention or access and things. Are those being connected? That's really what I was saying.
So can I say there's lots and lots in that. I mean, obviously this is a massive priority for us. I might come to Matthew just to ask what they're doing around the acute waiting lists around this. I know that there was some work done in another part of London, not with us, on the waiting list, to say when we're looking at recovery, could we identify any inequalities in the way in which we were seeing people that were on the waiting list, and I think the overall view was no, we couldn't see that. It was around clinical priority, but I think the bigger question is there an inequality in those that are getting onto the waiting list in the first place, which I think we probably need to do a lot more work on, and I think that comes back to the discussion that we had around vaccines, around how we actually engage with our local communities, and there's a huge amount more work for us to do around that. And I think the core 20+5 work that Gloria's been doing around identifying those, particularly with long-term conditions, and how we identify actually very small groups. I think it's 18, I might have got the wrong number there, 18 people that have multiple long-term conditions, and we know who they are and where they are, and how do we actually support them in a different way to make sure they're getting the right support from health services. So it's that kind of thing I think that we need to do some more work on, and we have started that work, but there is much more to do. I didn't know if any of my colleagues wanted to come in on that, particularly Matthew or Gloria, but that would be my response on that.
So let's bring in Matthew and Gloria, and I imagine Naz is wanting to come in on that as well, because I think some of what you've touched on, Susan, there is work going on in the outpatient transformation program that supports transformation of the way we do stuff, as well as a focus on recovering the numbers. And what I do know, I don't know about the overarching plan, but within the individual clinical networks that are looking at a lot of the areas where we have to achieve elective recovery, so where there's elective recovery planning, those networks were explicitly set up to both do that and in parallel to think about the end-to-end pathway and how it could be transformed to be more efficient and effective, and what support could be put in before people get onto the waiting list. So I can say confidently that in the clinical networks that is happening, and I think that approach is augmented by having joint leadership of secondary care clinicians and primary care clinicians, and a fairly good representation in those networks as well of a variety of people from across the system to help think in that way, including in many cases really good patient engagement work going on through the networks. But let me come to Matthew.
Thanks, Andrew. I'll come in on a couple of points. I'll do the electives and the inequalities piece first. I mean, I'd share Sarah's view if 2 points to make. I mean, in terms of those patients who are already known to us on the waiting list, you should be reassured, relatively speaking, that in Southwest London, overall our waits are low comparative to London and the rest of the country because of the hard work that lots of people have done, primary and secondary care, to sort of manage our recovery from COVID with all the facilities that we have in play right across Southwest London. So that means that anybody, you know, our waiting times, if you looked at inequalities of people who are on the waiting lists, then there isn't a disparity between who has picked its clinical priority and the waits are, as I say, comparatively low. There's much more work for us to do, of course, and we're ambitious to do it, but I think, Susan, you should be reassured in that regard. In terms of the patients who aren't yet coming forward, I think that's a much trickier question to answer on the basis that if we knew the answer to the question, they probably wouldn't not have come forward. So it's one of those unknowns, and it's why Sarah's absolutely 100% right. The core 20+5 is, I think, a crucial lever that we can use to really get underneath that, allied to some of the community connections that we've made, for example, through the vaccination programme and the good work that Gloria and others are doing to help support that. So I think it's trickier. I don't know absolutely the answer to the question, but if you ask me an opinion, I'd say there will be populations out there who are less likely to come forward, and as a consequence there will be some inequalities baked in, and talking from a Croydon perspective, we know half of the core 20+5 population for Southwest London is in the Croydon borough, and I've spoken to Sarah, Karen and others about how we can do collectively as an ICS, and obviously specifically within Croydon, work to focus on that population, you know, with growth and innovation funding focused towards that population. We need to make sure that it's used effectively with that population to identify any unmet needs. So I think it's work in progress. It's an excellent question. I don't have an immediate simple answer because it's a work in progress, but needless to say, it's on the top of our agenda, and rightly so. So hopefully helpful in that regard. My other comment, just briefly on the mental health piece, I mean, again, I'd endorse what Sarah said. I mean, there is a bit of a repeating pattern with this. It's a bit of a chronic issue, and it does go a bit cyclical. It's as difficult now as I've ever known it, both within established mental health institutions, also the community. Let's not forget the huge amount of primary care time that is spent managing mental health, but also and I would say carefully, wholly inappropriately, patients in extremis for increasing amounts of time in A&E departments, not just Croydon's, but we are definitely the most acutely sort of affected at this moment, and there's been some individual cases that I've been involved in and shared with colleagues which have not demonstrated the speed and access that these individuals absolutely and desperately need. So I wouldn't want to underplay the concern that it's raising. Now, creating a concern and then doing nothing about it clearly would be wrong. And to be fair, Sarah and the team have stepped up and are pulling together some people for conversations later this week, because we need to do some immediate work. We need to do some short-term work, but there's also a longer-term question about what's the answer to patients, whether they be children or older aged children or adults who are suffering a mental health crisis, of which there is an increasing number. Our response as an NHS and as a care sector needs to be better, and that needs to be a focus going forward.
Thanks, Matthew. Shall I bring Gloria in, because there's been quite a bit of reference to Core 20+5, Gloria, and you're leading on that. Do you want to come in?
Yeah, just to support what everybody else have said, there's a lot of work going on behind the scene, trying to pick up what and identifying areas where we have health inequalities and how we deal with that. And we've got figures now. We've got place figures as well. From next week, we're going to be meeting with each of the place leaders to look at some of their packs and the numbers, and just to make sure they recognize what we've given to them, and then agree on the best way forward in terms of priorities. And just to say, we are not just identifying, we are putting in intervention as well, as I think majority of our aware, we won the bid for the Core 20 Connectors program, community program. So we are not just going to be looking at the figures, we're going to be putting in an intervention, going to the community to understand some of these problems. Like Matthew have rightly said, it's about those unknown people that have not really accessed the service, and it's about unpicking that and looking at intervention to really help them to come forward. That is what we'll be doing, and we'll be updating as we go forward on that work.
Thanks, Gloria. Naz, can I bring you in now?
Yeah, sure. Thank you. I'm not going to go over the same points that Gloria and Matthew have made around the inequalities. What I did want to say was just on the outpatients bit, we are recruiting to a person to the BI team, so that we can actually look at some of this inequalities, particularly around referrals in, around patients who are DNA in, around then trying to come up with plans and action plans of actually implementing what we need to do to actually try and improve the inequality. The other bit I want to just bring up is that we are also looking at making sure that we're not widening the inequalities gap by what we are doing, particularly around digital IT and patient-initiated follow-ups, etc. So we're making sure that we've got a handle on that, and we're working very closely with the HIN around looking at the patients who are on the waiting list and actually scoping a piece of work to make sure that they're not getting disadvantaged. They're not populations getting disadvantaged by waiting on the waiting list for that length of time. And actually, then we can actually look at what we need to do with that population cohort. So there's an awful lot of work that is building up, as Matthew has said. It is not complete by any means, but everything is being scoped out at the present time.
Thanks, Naz. And then I've got Bruno, Patrick and Karen. Are you all coming in on this particular point, or are they new things? Bruno, I think yours might be new.
Yeah,
is that right? A new question. Karen, yours is a new question. Patrick, were you on this one?
Yeah, it's sort of addressing Susan's point, really. Shall I carry on? Yeah. Yeah, so just addressing Susan's point about inequality and adapting delivery in recovery. So another example of Andrew's outstanding leadership is the steer to each place and borough to secure clinical leadership specifically for population health management, a fundamental premise of which is addressing inequality. So that is one of the things that's changing to address that. And the other thing I wanted to point out was the anticipatory care model, which involves innovative approaches to engaging with patients using the additional roles and reimbursement staff rather than the rather rigid unitary model that we've historically used. So these are examples of changing delivery in recovery.
Thanks, Patrick. Right, Bruno, can I come to you?
Yeah, thank you, Andrew. Yeah, my question was around personal health budgets and the stark variation which there is in those, particularly the underperformance from Sutton. And I just wondered, Sarah, you said that obviously this is 2 months old, this data, whether things have changed at all or whether this still reflects the picture. But particularly my reason for querying this was because there's, in the commentary it said that overperformance in some boroughs had been encouraged to offset underperformance in others. But on the other hand, some standard operating procedures and other things being brought in to try and equalise performance. I'm just interested on what the situation is now and whether that's changed significantly, and whether we can expect that performance will be equalised in the relatively medium term.
Thanks, Bruno. Good question.
Shall I come back on that? So is Tonya still here? Is she gone? So,
sorry, I'm still here, Sarah.
Oh, Tonya, do you want to come back on this? I do know something about this, but you will know more detail.
Yeah. So just to give some background, so we offer personal health budgets in 4 areas: CHC for adults, children in receipt of continuing care, people who meet the criteria for the local wheelchair service, and the Section 117, those in receipt of Section 117 of the Mental Health Act. So just on that basis, it's very much driven by the population cohorts in your borough. So we absolutely recognise there's difference, though we do need to know, we want to do some validation to work out in terms of prevalence how many PHB should be in each borough for those areas. So we're doing some work on that. The largest, so the governing bodies where the largest proportion of PHBs are the personal wheelchair budgets at the moment. We recognise what's Bruno has said about Sutton, and Sutton are looking to bring some interim support into their CHC team to increase capacity. So we should hopefully see an improvement in their uptake. We are doing some shared learning around standard operating procedures for offering personal health budgets, and we're also working on exploring how do we increase the range of services we can offer personal health budgets. So we have a plan again for next year to do that.
Thanks, Tonya. And Karen, can I bring you in?
So I was just going to say, at this point of the year in future, I wonder whether we want to have a look at the key headlines to see whether, so it's difficult, isn't it? Most of the data is November data. We're sitting in March, and it's difficult to see whether actually we're unlikely to meet some of those national performance targets. You can kind of deduce it, can't you, if you look at performance and how it's traditionally worked through. But I also wonder whether there's a bit of judgment in the key headlines at this point in the year where we could say, you know, the national data is of this month, but actually our intelligence tells us that we may fail the targets in these particular areas. I was looking at SMI health checks and thinking we're very unlikely to make that target now, but it's not the only one. But it's just a bit difficult to say. So I suppose there's a bit of data, there's also a bit of judgment, but to also just share where in future we think we may not meet the national targets. Not something it's just
yeah. I think Karen's absolutely right. I think one of the issues is the level of data we can bring into the public domain, because it's, you know, the data has to be to make sure we check the data to make sure it's as accurate as it can be. What we tend to do though is to verbally update on areas, as I've done today, around the areas where we think there may be concerns, and we also share more up-to-date data which may not be validated with committees. So people, and we also, when we discuss, you know, when I discuss with, say, the chief execs of providers, if we're looking at something like elective, we almost have the kind of the most up-to-date data that we possibly can have. So I think on an operational footing we can do that. I think the issue is that when we get to the point where we're reporting into public, we want to make sure that that data is validated, and therefore sometimes it's a bit older than we would like. I think what we need to try and think about is, can we bring more unvalidated data into the public domain, and you know, and assumptions. But I think the verbal updates we can give will help the board and the ICS going forwards in public to understand what the current position is.
Thank you, Sarah. Liz, shall I bring you in?
Thanks. I think Sarah's just raised a key point, because, you know, from the point of view of transparency and the residents of South West London, you know, feeling confident in services. If I can absolutely see the issue about data needing to be validated, but if it only goes into the public domain once it's fully validated, and that takes, what, 4 months, perhaps, something like that is what the feeling is, then it leaves those of us who are representing the patient voice in a bit of a conundrum. You know, because it means that, fine, it's being fed into committees that aren't meeting in the public domain, but it, you know, if there are issues that are shaping up about missing targets, it does feel important that in some way those of us who are representing the public are made aware of that, and perhaps if further thought could be given to that. Thanks.
Thanks, Liz. Can I just test with you as well, though, when you're saying that? Is it that you think you should be cited on the data, or that you think you should be cited on the processes that are in place in the system to react to the unvalid data in a real-time way? Because there's a difference, isn't there, between how we operationally manage as a system and how we report up to the board and think about the strategic themes that emerge from what's been happening over a period of time. So I guess it'd be helpful to understand the.
Yes, sorry, yeah, I probably wasn't very clear. Sorry, it wasn't actually either of those. I think simply knowing about processes is important, but not entirely sufficient. It was some way of getting perhaps a sense of the way the data is going, even if the actual data can't be properly shared, a sense of the trajectory for knowing whether targets aren't going to be met. So that was the point that I was trying to make, albeit rather unclearly.
No, that's fine, Liz. And Bruno, do you want? I think you were coming in on the same thing. Are you? So do you want to?
Yeah, it's exactly the same thing. I think that Liz is right that it would make it easier, because in terms of the sort of relationships that there are within the voluntary sector, and I'm sure amongst health watches too, there are time lags in relation to discussions and things like that. And certainly when I was a CCG board member over in northwest London, it was an advantage that there was data earlier in terms of trying to have discussions with colleagues in the voluntary sector over in that area. So I think that what Liz says is right. I don't know quite how you resolve it, but I think that it's fundamentally right.
Can I say something on that? I do think at the local level people have the up-to-date data. So where the voluntary sector will be involved with the local borough discussions, you know, the most up-to-date data will be discussed at those committees, I'm sure. I think the important thing for the board is that even though you might not have today's data in front of you, you are getting a realistic update on what is going on in the system, and as Andrew said, the strategic kind of direction and raising any risks that there may be, which is what I've done today with things like mental health in A&E. So I think, you know, we just need to make sure that we can have as much up-to-date data in the operational planning as we possibly can, which will be at borough level mainly.
Thanks, Sarah. And I think there is more work to do on this, because we know that the data we get as a system at the moment is not as timely or as good as it could be, and there is going to have to be work on our intelligence function as a system, which will be firstly making sure that we've got our data really good and timely, and secondly being clear about how we use that collectively as a system for all sorts of purposes, but that includes performance and planning, etc. So I know there will be a lot more work going on this over the next 6 months, and we probably just need to make sure that you're kept cited on that, because I think it's really important. Okay, shall we move on from the performance report to the QPOC committee report? Pippa.
Thank you, Andrew. So you've all got this, so I'm going to take it as read. I think we've probably had a really good discussion about performance. So you can see the areas that we covered, and much of that we have discussed today. The only thing I'll draw to your attention was we were given some Q2 data on childhood vaccinations, which is set out in my report. So you can see where we are and where South West London sits in comparison with the other London areas. We also had a, well, our reporting for quality and what that looks like is evolving, and evolving in a very positive way. There's some improved, Gloria is setting up the system architecture around the System Quality Council, and the actual report that's coming into QPOC, which will evolve into the Quality Oversight Committee for the ICB, is developing, and you know, we've got 2 more opportunities to do that before it formally moves over to the ICB. The oversight metrics for place, ICS and provider collaboratives were presented to the committee, and how that's going to look and what the oversight of that's going to look like at South West London level will be part of what I've just discussed. We had an update on CCG complaints. We've asked for some further information about not just the numbers and the areas, and these are CCG complaints, but actually the learnings. So what is changing as a result of those complaints? So we're going to get some further updates on that. You can see at the bottom of page 2 that we had a good look at the progress on the safe and well-being reviews that are being undertaken. These are for people with a learning disability and or autism, and follows on from a safeguarding adults review, so that we got good assurance around that. It's work in progress, and we're going to get a further update in April, but it's going well. The only other thing I'll draw to your attention, again, we've talked about it, and Matthew's mentioned it. Again, we had an update on the children and young people with mental health who are presenting at Croydon A&E. We'd looked at the other boroughs at a previous meeting, and we've talked a lot about that today. We also had our first update on the core 20+5. So probably Susan and I, who sit on the QPOC committee, were less well cited on this, but I think I've given you a bit more detail there because I think it's important that people are aware of what that really helpful programme looks like. I think based on the conversation that we've just had, being clear on what our ambition for some of these areas are and how we're going to measure impact around access, experience and outcomes, I think is probably one of the key challenges we need to think about. But it's really good that we know the areas where we need to do some further work, and I think Matthew and others have given us an update on that. So the interventions will be the thing that needs to be tracked going forward and supported. We had a good update on the Ockenden report with a quarterly update. We get quarterly updates on that, and that will need to form part of our transition to ICB when that happens in a few months' time. And then we also looked at our risk register, and you'll see there that we've agreed that we will look at that in full at our June meeting, so that we're sure that the handover to the ICS is complete around quality risks. Happy to take any questions, or other colleagues on the committee are, I'm sure, but we've probably covered a lot of it.
Thanks, Pippa. That was very comprehensive. Are there any questions for Pippa on any of that or on the report? No? You've covered it all, Pippa. Thank you. Shall we go then to David to give us a verbal update from the recent Remuneration Committee?
Yes, thank you, Andrew. So the Remuneration Committee met on the 21st of February. We had a paper in relation to the pay framework for the executive directors of the new system of the new ICB. Discussed that paper, and a recommendation was put to part 2 of the governing body meeting, which met earlier today and approved the recommendation from the remuneration committee.
Thanks, David. Any questions on that? No? Okay, well, that concludes the scheduled parts of the meeting. We're now on to public questions. Not had any questions submitted by email or through the meeting. Are there any questions from anyone in attendance? No. Okay. Well, I haven't been notified of any other business, so that just leads me to close this governing body meeting. It's been a real privilege to chair this board for the last 2 years, and thank you all for your incredible support and for your kind words today. And let's close there. Thank you, everyone.